Hello, everyone, and welcome to today's webinar, Capillary Electrophoresis for Hemoglobinopathy and Thalassemia, Evaluation, a Case-Based Approach. I'm Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Sabia Incorporated. To learn more, visit www.sabia.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. We do want to let you know that we will have a survey after this webinar, and we greatly appreciate your participation in this. I'd like to now welcome our speakers, Dr. Matthew Wagner, Emory University, Georgia Technical Institute of Technology, and Dr. Mark Girton, Clinical Assistant Professor at the University of Michigan, Department of Pathology. Dr. Wagner, you may now begin your portion of the presentation.
Thank you for that introduction. As she said, my name is Dr. Matthew C. Wagner. I'll be presenting a first little bit of this presentation on capillary electrophoresis for hemoglobinopathy and thalassemia evaluation, a case-based approach. We decided to do a presentation from a case-based perspective because it's really more useful to look at the entire patient chart when we are looking at evaluating, at diagnosing, at figuring out what these electropherograms mean. However, the capillary electrophoresis technique is a little bit newer of a technique for the evaluation of hemoglobinopathies, so I'm going to start with a brief review of the principles behind how capillary electrophoresis works. Capillary electrophoresis takes place within a capillary, and this is a separation of proteins based on size and charge, very similar to the electrophoresis you see on gel electrophoresis, except it's taking place in a moving fluid matrix. We inject a very small amount of the patient's sample into one end of the capillary, and then we apply our electric voltage. This electric field is so powerful that it physically pulls the liquid buffer through the capillary, and the individual proteins, as they travel through the capillary, are also feeling this electric field and are separating out by size and charge. At the far end of the capillary, these proteins pass through a detector tuned to 415 nanometers, such that we're only going to see the hemoglobin proteins passing through the detector. That as these proteins have separated out in the capillary, we then see them pass through each of the in sequence through the detector, and we see them separated out in sequence. Interestingly, this same principle is applied to many other testing analytes, including serum protein electrophoresis, hemoglobin A1C, carbohydrate deficient transferrin, and a version of immunofixation called immunotyping, using these same principles, just looking for different analytes or in the presence of different antisera. This gives us a finer resolution and separation of proteins when we're looking at hemoglobins, and gives us standardized migration positions. When we go to interpret the electropherogram that comes out of the capillary electrophoresis instrument, we can view it as an improved alkaline gel pattern. The buffer that's being used by the capillary electrophoresis instrument is alkaline in nature, so the separation of the different proteins is going to occur in the same order that we see on gel. On gel, we're used to seeing the bands for A, F, S, and C going down from top to bottom, whereas on the electropherogram, from left to right, we see that same separation of A, F, S, and C. However, the increased resolution of the capillary instrument enables us to get much more exact and repeatable migration positions for each of the known hemoglobins. For example, we even see separation of hemoglobin C and E from hemoglobin A2. Each of those three hemoglobins has their own distinct zone on the pattern and can be easily told from one another. We also see separation of hemoglobin S from hemoglobin D Los Angeles, separation S from the Lepore variants, and this finer definition and repeatable migration position means we can look at actual X values, the X position of each of these hemoglobins on the graph to give us an insight as to which variant we may be looking for. Further, the technique is entirely automated and removes any of the technique-dependent aspects we have when we're dealing with gel. If we have somebody who is not quite as experienced with running gel versus a seasoned expert, you may get a little more variability in your results. This is not the case in capillary due to its extremely automated aspect. Having covered these sort of basic principles of how to regard the capillary electrophoretic pattern, we're now ready to move on to the cases that Mark has put together for us.
All right, thank you, Matt. Again, my name is Mark Girton, a pathologist at the University of Michigan, and I have a series of cases to go through. Case 1, a 30-year-old female presenting for prenatal care. Hemoglobin A2 is decreased. On the right side of your screen, you will see an electrophoregram with a major peak representing hemoglobin A. And below it, you see the fractional percentage of each hemoglobin, A being 98.1%, hemoglobin A2 being 1.9%, which is just slightly below the reference interval that you see on the right, which ranges from 2.0 to 3.8%. So in this case, when we look over at the CBC data in the top left, we see an anemic patient with a hemoglobin of 6.8, and her MCV is decreased at 69.2, so that would be a microcytic anemia. And we see a CBC description above the CBC data that describes the smear micrograph at the bottom. So we have a microcytic hypochromic anemia with occasional elliptocytes, and the interpretation says correlate with complete iron studies and hemoglobin electrophoresis. This patient had no current iron studies, no known transfusion history or prior hemoglobin study. So the only abnormality here, again, is the slightly decreased A2. So the interpretation in this case, hemoglobin electrophoresis demonstrates decreased hemoglobin A2. Iron studies are recommended and iron repletion if indicated. Repeat hemoglobin electrophoresis once iron replete. The reason for that interpretation is that in the context of a microcytic hyperchromic anemia with moderate anisopoikilocytosis, including this pencil/cigar morphology or elliptocyte morphology, this is presumptive iron deficiency anemia until proven otherwise. And with a hemoglobin of 6.8, this is actually a pretty severe case, likely, that would pretty routinely result in a at least minor decrease in hemoglobin A2. So there are many causes of decreased A2, can be physiologic in the fetus and neonate. Iron deficiency anemia is probably the most common reason that we see clinically. Anemia of chronic disease can be included in this collection of reasons for decreased A2, along with sideroblastic anemia, lead poisoning, myeloid disease, aplastic anemia, hypothyroidism, and chemotherapy. Something that sometimes comes up is whether a decrease in hemoglobin A2 is possibly representing thalassemia, specifically alpha thalassemia. It's somewhat unlikely, or much less likely than iron deficiency anemia, especially. Thalassemias tend to present with erythrocytosis and a Menser index, that is the MCV divided by red blood cell count below 13. And on the other side of the thalassemia spectrum, beta thalassemia drives increased production of hemoglobin A2. So we wouldn't expect a decreased A2 in that case. Next case, 37-year-old at 13 weeks, 2 days, presenting for prenatal care. In this case, hemoglobin F is elevated. On the right side, the electrophoregram shows a third peak in the middle of hemoglobin A and A2 that's marked as hemoglobin F or variant, quantified as 2.1% of total hemoglobin complement in this case. It is slightly above the threshold for expected hemoglobin F, which is less than 2%, over here on the right. The CBC in this case shows slightly increased white count and a slightly decreased red count, otherwise is pretty unremarkable. And the peripheral smear here does not have the kind of telltale traits of, say, iron deficiency anemia that we saw in the last one. So overall, fairly unremarkable. So the interpretation in this case, hemoglobin electrophoresis demonstrates a mild elevation of hemoglobin F, less than 5%, which may be a normal finding in pregnancy. So beside a mildly low red count, this is an unremarkable CBC and peripheral blood smear, and increased F synthesis is something that we know is associated with pregnancy. So in this case, this very minor increase in F likely represents a benign elevation of F. Case 3, this is a 50-year-old male with a history of mantle cell lymphoma, status post-chemotherapy, and with evaluation for an autologous stem cell transplant. On the right side in the electrophoregram, we again see an elevated hemoglobin F or hemoglobin variant, so at 2.6%. So again, above that reference point of less than 2% that we expect and for normal adults. Looking over at the CBC indices, we see this patient is anemic. In this case, the MCV is normal, so it'd be a normocytic anemia. Additionally, the patient has a low white count and almost critically low platelet count of 10,000 per microliter. So pancytopenia, which goes along pretty well with the history of mantle cell lymphoma with chemotherapy. In this case, we run an acid gel that confirmed the hemoglobin F here and A that we see on the capillary electrophoresis. Hemoglobin A2 is not seen as a separate band in acid gel. It'll be in with the hemoglobin A band there. In the micrograph below, we see red cells, red blood cells, erythrocytes, a rare platelet, no white cells, so that is kind of associated, or it further confirms our history of mantle cell lymphoma with chemotherapy and the CBC indices. So the interpretation in this case, hemoglobin electrophoresis shows a mild increase in hemoglobin F. Mild elevations of hemoglobin F, less than 10% typically, are seen in many hematologic processes, including anemias, lymphomas, leukemias, myeloma, malignancies metastatic to the bone marrow, and with marrow fibrosis. As I mentioned, there was only one platelet in that field of view, no white cells on the previous slide micrograph, consistent with the patient on chemoablative therapy. And in this separate micrograph, in the bottom of your screen, we see a myeloid precursor consistent with a myeloid left shift, which is often seen in a regenerating bone marrow. Case 4. It's a 55-year-old female with a pre-op visit for a planned total right knee replacement. On the right side, the electrophoregram shows two peaks, hemoglobin A and hemoglobin A2. We see that hemoglobin A2 is elevated above the top of the reference interval of 3.8% at 5.2%. Looking at the CBC indices in the top left, we see this patient has a high red blood cell count, a concomitant anemia, hemoglobin 11.6 is low, and that anemia is microcytic. The MCV is decreased at 67.5. So these findings of an increased A2 are compatible with a beta thalassemia trait, so it'd be a heterozygous beta thalassemia. Erythrocytosis and microcytic anemia is characteristic of thalassemia. Increased A2, which is alpha-2, delta-2 globin genes, occurs in disorders with reduced beta globin, aka beta thalassemia. And patients with these characteristics should have iron studies and be iron replete for definitive interpretation. You might have noticed below the CBC data, there were no iron studies. However, the patient was noted to be on a multivitamin that included iron, and the patient had no transfusion history of note. Case 5. It's a 10-year-old male with appendicitis and a reported history of sickle cell anemia, or hemoglobin SS. The electrophoregram on the right, we see 4 peaks. We see a small amount of hemoglobin A, 18%, hemoglobin F at 8.1%, hemoglobin S, 68.2%, and hemoglobin A2, 5.7%. So this is an interesting pattern for sickle cell anemia. We may expect that a patient with sickle cell anemia, hemoglobin SS, may have a transfusion history, which would be fairly routine in that clinical setting. Look over at the CBC indices. So this patient has an elevated white count, which kind of goes along with this history of appendicitis. He does have, interestingly, a microcytic anemia. Anemia is, of course, part of sickle cell anemia. However, typically these patients would be have a normocytic anemia. So that does raise some potential for an overlap with some other cause for anemia, such as thalassemia or iron deficiency anemia. Additionally, this patient has no history in his fairly short but significant 10-year lifetime, no significant history of transfusions, sickle cell crises, or hospitalizations. This is an interesting history for a patient with hemoglobin SS. It's quite unusual to live through 10 years of life without a single transfusion, any sort of sequelae from sickle cell crises, and no hospitalizations. So the interpretation in this case, given these this odd constellation of findings, including the microcytosis, is the findings are compatible with a sickle/beta thalassemia due to the presence of hemoglobin A with no history of transfusion. So this would be best subclassified as a hemoglobin S beta plus thalassemia. Beta plus denoting that this thalassemia does result in some hemoglobin A production, just not the normal amount. So of note, this patient had a hemoglobinopathy test at around 13 months of age, which is interpreted as likely sickle cell disease with a history of transfusion. This interpretation was likely incorrect. The patient had no documented transfusion history, would not have received a transfusion so early in life, likely, as hemoglobin F at that point would have been protective. And I guess I should note that the acid gel here does confirm the pattern that we see on the hemoglobin electrophoregram with S, A, and F. And again, we won't see a distinct A2 peak on acid gel. Case 6, the 30-year-old female at 13 weeks presenting for a routine prenatal visit. Looking at the electrophoregram on the right, we see 3 peaks, a major hemoglobin A peak at 74.9%, hemoglobin F peak at 23.4%, so markedly elevated above the expected less than 2% complement that we would routinely see in adult patients. And a hemoglobin A2 of 1.7, so that's a little bit below the reference interval that we see here of 2% to 3.8%. Looking at the CBC indices, this patient does not have anemia and is normocytic. They do have some abnormalities in MCH and MCHC, so mean corpuscular hemoglobin and MCH concentration. Also, the red cell distribution width, which essentially is a measure of how variable in width the erythrocytes are, is increased. And on acid gel, we see the two peaks here for hemoglobin A and F. So the finding of an elevated hemoglobin F at 23.4% is compatible with heterozygous hereditary persistence of fetal hemoglobin, HPFH. Hemoglobin A2 is decreased, and this decreased A2 can be seen in both inherited and acquired conditions, which is just an interpretive note. That's pretty standard. HPFH is associated with some ethnic groups in which 10 to 15% of individuals have slightly increased hemoglobin F. Other indices are typically normal. The percentage of hemoglobin F in these cases is pretty widely variable, and can be as low as 1 or 2% by some definitions. So it can be a little bit tricky to interpret depending on the clinical context. Case 7. This is a 14-year-old male with hemoglobin SS disease, so sickle cell anemia, complicated by moyamoya and cerebrovascular accident. So moyamoya is a radiologic finding, usually of the neck arteries, in which repeated occlusive events in those arteries have caused collateral vessels to attempt to reroute blood flow around the more major vessels. And on radiologic imaging, this appears as puffs of smoke, which is called moyamoya in Japanese, I believe, or roughly translated. And stroke, cerebrovascular accident, is not an uncommon symptom or complication of sickle cell anemia throughout their lifetime. So this patient with reported hemoglobin SS disease and the electrophoregram on the right, we see, interestingly, 4 different peaks. Hemoglobin A at about 56.5%, a small hemoglobin F peak at 1.4%, hemoglobin S 39.1, and then an A2 of 3% in the normal reference interval there. And in the smear micrograph here, we see quite a bit of anisopoikilocytosis of the red cells. That's a way of saying many different sizes and many different shapes. And some of those shapes include these elongated sickle type cells that you may see scattered around the smear. So that would be consistent with the patient's hemoglobin SS. However, the question that is raised, given 56.5% hemoglobin A, what's going on here? So we should always remember in our assessment, iron studies and transfusion history, along with quick clinical history, is very useful in interpretation. So in this case, the interpretation is the findings are compatible with homozygous hemoglobin SS undergoing periodic treatment with red blood cell exchange or transfusion, accounting for the hemoglobin A fraction in this case. So as mentioned, the transfusion history is key to making the right diagnosis. Without this history, it may be unclear whether this was a transfused hemoglobin SS patient versus a patient with sickle cell trait. So that'd be hemoglobin AS. Hemoglobin F is usually about 5 to 10% in sickle cell anemia, but may be higher, especially with hydroxyurea therapy. Case 8. A 32-year-old male with hemochromatosis and occasional blood transfusions. This patient is presenting for consideration of autologous stem cell transplant. The electrophoregram on the far right, we see four peaks, a small hemoglobin A peak, 15.3%, the hemoglobin F peak, 40.2%, Hemoglobin E zone peak, 39.8%, and hemoglobin A2, 4.7%, which is quite a bit above the hemoglobin A2 range that you'll see in the reference interval below the electrophoregram. On acid gel, we see A and F bands, no other bands there. And looking in the top left of the CBC indices, we see this patient has a low red count and they are anemic with a hemoglobin of 8.1. Their MCV is 71.1, which is low. So this is a microcytic anemia. And we also see several other red cell parameter abnormalities. This patient additionally has thrombocytosis, platelet count of 705, so quite elevated. Looking down here at the the blood smear micrograph, we see pretty significant red cell abnormalities. Prominently, a lot of these cells that look like targets, or we call it target cells or dacrocytes more scientifically. We also see occasional cells that appear to be folded, so these folded cells, and then various other morphologies. Additionally, we see nucleated erythrocytes. So we would not normally expect to see those in the peripheral blood. Of course, we would expect to see those in the bone marrow. And you can see the increased background platelets that correlates well with that increased platelet count. So this patient has hemoglobin E and some hemoglobin A. So, and quite a bit of hemoglobin F and elevated A2. So this raises a few possibilities. So we could talk about this possibly being a heterozygous hemoglobin E or an E trait. However, a lot of this data would argue against that simple explanation, given that we have elevated hemoglobin A2 and we have what appears to be a pathogenic disease, which E trait by itself is usually silent. So the findings suggest heterozygous hemoglobin E and beta thalassemia. And of course, in the interpretation, we say clinical correlation is recommended, including with prior studies and any therapies. So the expected E contribution in heterozygous hemoglobin E is about 20 to 30% for E trait. In this case, we suspect beta thalassemia 0, and that would result in no hemoglobin A made by the patient. Hemochromatosis, this patient's this patient's conditions typically requires therapeutic phlebotomy, actually, to prevent iron overload. So the transfusion history for this patient is a red flag that there may be another disease state like hemoglobinopathy. Hemoglobin F may be elevated in hemoglobin E with thalassemia, like we see in this case. Hemoglobin E runs with hemoglobin A on the acid gel, explaining why we don't see a separate band. And on peripheral smear, we saw the nucleated cells and target cells, folded cells, and other morphologies, which goes along with E beta thal 0. And then just lastly, to tie this one up, in case it wasn't very obvious, the hemoglobin A here is likely from transfusion, not from the patient's own production. Case 9. This is a 32-year-old female with a coming in for a prenatal visit. On the right side, the electrophoregram has 3 peaks. Hemoglobin A peak, 60.8%. A very small hemoglobin S zone peak of 0.5%. And then this abnormal hemoglobin plus hemoglobin A2 peak in the A2 position. Looking at the CBC indices, this patient has no anemia, but does have a very, very slight microcytosis. MCV is 84.4, just below the reference, bottom of the reference interval there, 84.9. Slightly increased platelets. And looking at the acid gel here, we have a band in the A position and a band that is traveling near, but perhaps not quite at the S position. So the interpretation in this case, capillary electrophoresis for hemoglobin separation shows two major peaks, one in the A zone and one large peak in the A2 zone. Acid gel just shows that A peak and a band between the A and S positions. So the quantitative hemoglobin A2 is markedly elevated, which I think I had mentioned, but so this is not likely an A2 variant. Both capillary electrophoresis and acid gel electrophoresis would suggest hemoglobin O Arab trait, but other more rare hemoglobins, so perhaps hemoglobin Chad or hemoglobin E Saskatoon, are possible. So for definitive characterization, a new blood sample may be sent out for referral. So the teaching point here is hemoglobin O Arab, which is a rare, but among the rare hemoglobinopathies is somewhat common. It runs with hemoglobin C on alkaline gel and near/overlapping hemoglobin S on acid gel, as we see here. And on capillary electrophoresis, it runs in the A2 zone. So definitive characterization, like I mentioned, would probably need to be done by a genetic study. Case 10. It's a 31-year-old female with a history of sickle cell disease, polysubstance abuse disorder, and complaint of sickle cell pain crisis and fever. On the right side, we see an electropherogram that has 4 to 5 peaks. Hemoglobin A, 20.6%. Hemoglobin F or variant, 1.4%. Hemoglobin D zone, 74.5%. And I should know that the peak in the hemoglobin D zone is a split peak, which likely represents or may represent two variants running close together, and hemoglobin A2 at 3.5%. The CBC indices, we see hemoglobin that is decreased, so anemia, and slight microcytosis here. MCV is slightly low at 81.3. And if we look at the smear micrograph, we see quite a bit of anisopoikilocytosis, so lots of shapes and sizes. Those shapes include elongated sickle shapes, like we would expect to see on perhaps a sickle cell anemia patient's blood smear. This patient had no previous iron studies and was noted to have had a red cell exchange on the same date, but after this CBC was run. So the interpretation in this case, findings are compatible with the patient's known hemoglobin SD undergoing periodic treatment with red blood cell exchange or transfusion. So the teaching point here is that hemoglobin SS is not the only hemoglobinopathy that will induce sickle morphology on your peripheral blood smear. Hemoglobin SC, hemoglobin SD, and S trait with an asterisk may also sickle. Hemoglobin D, interestingly, runs with or near hemoglobin S on alkaline gel and with hemoglobin A on acid gel. No gel was run in this case as the patient had previous testing. The peripheral blood smear shows occasional sickle cells, as we would expect in a sickle cell anemia-like hemoglobinopathy. And the asterisk on the hemoglobin S trait up there about sickle cells, it may sickle very rarely and probably then only in very ill patients and or with concomitant disorders that induce oxidative stress. So I routinely have to teach trainees about this, that seeing a sickle cell in a patient with a reported sickle trait is exceedingly unlikely. So they should always dig a little bit deeper into the clinical history and question the sickle cell trait diagnosis in that case. And with that, that wraps up all of my cases. I want to turn it back over to Matt. He has 2 additional cases to show of interest.
Thank you, Mark, for that review of those 10 interesting cases. I have prepared 2 additional cases here at the end, but I should note that not having actual contact with patients, these are entirely fictional cases. These are cases that are assembled data from a number of different publications, a number of different sources, a number of different images in order to have an illustrative case, but they do not represent, strictly speaking, a single patient. Here in case number 11, we have our fictional 27-year-old female patient previously diagnosed with sickle cell anemia who has undergone a recent transfusion. Looking briefly over the CBC, we note the anemia which we would expect to be associated with sickle cell anemia. And we see in the broad strokes, the profile on the electrophoregram is also about what we would expect. We see a low amount of A, we see an elevated amount of hemoglobin F, likely from hydroxyurea treatment, and a large proportion of hemoglobin S. However, upon closer examination, we notice a number of other peaks are present. There is a small peak between hemoglobin F and hemoglobin F. We see another peak between hemoglobin A2 and hemoglobin S. Even hemoglobin S itself has a distinct shoulder to it. This is clearly an out-of-the-ordinary profile. If we look at the acid gel electrophoresis in the center of the screen, we also note a few additional bands here as well. Well, what exactly is going on? This was a previously diagnosed patient with sickle cell, and now suddenly we have all these other peaks present. This happens to be a drug interaction. This is the interference of the licensed drug oxyberta, otherwise known as voxelotor, in a sickle cell patient. This drug has been specifically designed to bind to the alpha globin chains of all the hemoglobins in the patient's blood, of any of the hemoglobins in the patient's blood, in order to lock a certain proportion of that hemoglobin into an oxygenated state. By locking that hemoglobin into an oxygenated state, it is hoping that we will alleviate some of the anemia, some of the sickle pain crisis, some of the sickling procedure that happens in sickle cell patients. However, the fact that this drug is physically interacting with and binding to the hemoglobins in the patient's blood means that we are seeing an interference. Small fractions of the blood with the oxyberta bound to it is separating out in our electrophoregram because, of course, it has a different size and charge. This leads to the shoulder on the hemoglobin S and the 2 distinctive peaks between F and S and S and A2. We first encountered this particular profile when it began being sent into our result interpretation escalation group, and we were just as puzzled as anyone else because we happened to be getting samples from those patients who were in the clinical trial for this drug. The drug was subsequently approved and went into general use, and we began to see a lot more of this particular interaction come in for assistance. However, very recently, just within the last month, this drug has subsequently been voluntarily withdrawn from the market. And as such, this specific case, which I very carefully put together in order to instruct you all, is becoming somewhat moot. However, we do need to be aware that drugs which are designed specifically to interact with hemoglobin are going to lead to interactions like this, and, as with oxyberta, would likely cause interaction, additional peaks, shifted peaks on every technique which is used to fractionate hemoglobin and examine it, just as much with HPLC as it is with capillary electrophoresis. Our second case here, again, a fictionally created case, is a case of a 43-year-old male recently diagnosed as diabetic. However, once he went on insulin therapy, he began experiencing hypoglycemic events. In other words, his blood sugar began crashing very suddenly. Looking at the CBC, we see nothing particularly out of the normal. Everything is within normal ranges. However, when we look at the electrophoregram, we note additional peaks out to the left side of the hemoglobin A. Not just a single peak, but multiple little peaks. This is clearly an abnormal electrophoregram. On acid gel, we don't see anything in particular out of the normal. What could be going on with this patient? Well, this patient happened to be diagnosed as diabetic on an HPLC system, and that diagnosis, it turned out, was in error because this patient has inherited a hemoglobin variant called Hemoglobin Wayne. Hemoglobin Wayne is an alpha globin variant which is found in Caucasian populations. It is rare. It is a rare frame shift mutation resulting in two distinct variant peaks which are known to interfere with multiple HPLC hemoglobin A1C methods. It may appear either as a peak suspicious of hemoglobin E, or it may co-elute with hemoglobin F and hemoglobin A1C on HPLC, causing an elevated A1C and potentially leading to a misdiagnosis of diabetes. Interestingly, this particular variant causes no such interference on the Sabia hemoglobin A1C method. Both of the variant peaks are plainly visible, well separated from hemoglobin A and A1C, and a normal A1C value can be seen and reported. This particular patient was fortunately caught and was thought to have his hemoglobin screened because after these hypoglycemic events, they found that he had a very discordant glucose when compared with his supposed A1C value. This is a strong reminder to clinicians that discordant results is always a clue to look closer. In the case of discordant glucose and A1C results, it may suggest an interference due to hemoglobinopathy, such as a variant interference or an alteration in the patient's red blood cell lifespan. Screening for hemoglobinopathies would be recommended in the case of discordance between glucose and hemoglobin A1C results. With that, we come to a conclusion of our presentation on hemoglobinopathy screening, and I hope that these cases have clearly illustrated to you that although the capillary system gives you a much more advanced, better resolution on your electropherograms, it is still important to review the patient's entire chart, to look for discordances, to look for deeper understanding, to slightly different presentations, and in order to come up with the correct diagnosis for the patients under your care. With that, I believe we are ready to take any questions that the audience may have.
Thank you for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located below the slides, and we will answer as many of your questions as we have time for. Let's go ahead and get started. Our first question says, you mentioned the hemoglobin position. Where can this be found if we are currently using a Sabia system?
Okay, I believe that's a question for me. That's sort of a resources question. What sort of resources are available for knowing the exposition of particular variants? Sabia does have an online resource for looking up the exposition of some hemoglobin variants that we have seen commonly and we have been able to genotype. However, there is a fairly exhaustive publication out there that was published in AJCP. It was a collaboration between the Henri Mondor Hospital in France and Mayo here in the US. The first author is Jean Rieu, and it is titled Precision of Capillaris 2 for the Detection of Hemoglobin Variants Based on Their Migration Positions. As part of the supplemental resources available with that publication is a downloadable spreadsheet, which is nothing but a list of about 400 hemoglobin variants, as well as the exposition in which those variants are known to migrate. I know that I myself use that particular resource quite often in helping with result interpretations. So I would absolutely recommend other users look up that particular resource and download that spreadsheet.
Excellent. Thank you so much. Our next question, moving right along, it says, of the cases shown, some had minor discrepancies and some cases had significant discrepancies. For example, elevated hemoglobin F in the case of pregnancy versus HPFH. How do you distinguish between a truly discordant result and a non-standard presentation of an otherwise typical case? Is it all a degree of discordance, or should the potential for clinical impact be a factor in what raises the alarm over slightly discordant results?
Yeah, thanks for that question. So it's a pretty complex topic. So to keep it simple, hemoglobin F elevations in pregnancy are routinely low, below 5%, and they are also routinely benign. Whereas hereditary persistence of fetal hemoglobin, hereditary persistence of fetal hemoglobin is actually a collection of many diseases. Some are deletional, some are non-deletional, and just quickly, a lot of them will also result in other abnormalities. I didn't dwell on this, but in the case that I showed, there was actually a slightly decreased hemoglobin A2. That's somewhat routine for deletional HPFH cases because they involve the deletions in the beta globin gene cluster, which often include the delta gene as well. And then also just percentage-wise, hereditary persistence of fetal hemoglobin typically results in a hemoglobin F in the range of 15 to 30%, depending on the exact underlying cause. However, there are probably rare cases where you can see lower hemoglobin F, but again, I guess clinically that wouldn't really be that important to diagnose typically. And so I guess I would just focus on kind of broad strokes. Generally 15 to 30% F is more likely to represent hereditary persistence, and below 5% is likely not to represent hereditary persistence of fetal hemoglobin.
Excellent, thank you. All right, moving along here, we have a ton of questions, so let's try to get through as many as we can. Our next one asks, do you have any shareable reference material, or what types of training does Sabia offer outside of this webinar for interpreting difficult cases?
Okay, so for Sabia specifically, we do offer online training courses using the 360 Learning app, which all you have to do is basically request a training, and we can sign you up for what amounts to fairly basic training and then a little bit more advanced materials. We can't go too far into detail because then you start getting into very esoteric hemoglobins and combinations which aren't seen very frequently, and it becomes a little more elaborate. But we do make those available to any Sabia customers, training webinars available online specific to interpreting the electrophoretic patterns. As far as interpreting difficult cases, we also have the result interpretation escalation group. If you encounter a particular pattern in isolation and you can't seem to figure that out, or would just like another pair of eyes to look at a particularly difficult case, send it into the Sabia technical support team, and it will be escalated up to result interpretation escalation and will literally end up on my desk. And we try to give a nice, comprehensive, but not overly assured interpretation of what the pattern is consistent with, and sort of offer you some ideas of what you may be looking at. Of course, extremely esoteric things you would have to probably reflex up to genetic analysis if it's clinically indicated, if it's something that is considered significant enough to actually have a strong clinical impact. But those are some of the resources that we do offer for help in interpreting the capillary electrophoresis.
Great, thank you. All right, we have a two-part question next. So this says, can we measure HBD and HBE using capillary electrophoresis? And can S be separated from D on the capillaris to estimate the percentage of each?
Okay. So measuring hemoglobin D and hemoglobin E is, both of these are straightforward. They both have individual zones on the capillary electrophoretic pattern, and in isolation, if it is a D trait or an E trait, you're going to be able to quantify those just as readily as you would quantify a hemoglobin S trait. Of course, you would need to confirm that it is hemoglobin D or E with a secondary technique. As far as hemoglobin S separating from hemoglobin D, unfortunately, those two peaks, as we saw in the nice example that Mark showed us, those two peaks migrate very close to one another. And as such, because they are overlapping, we can't really do a 100% accurate estimation of the two peaks in isolation. For that, actually, I believe they both migrate fairly close to one another in HPLC as well, which of course is another separation technique that's quantifiable. Am I right about that, Mark? Are you aware of the close migration of S and D on HPLC, or are they more separated?
You know, my familiarity with HPLC is limited, and I'm not sure. Of course, E runs with A2, but I'm not sure where D runs. I'm sorry, I can't help.
That's okay. I believe they are fairly close. I think they're a little more separated than HPLC, so it may give you a little bit better of an estimate in that very specific case. But that's simply the nature of the hemoglobins and where they happen to migrate or elute. So S and D, to summarize S and D on capillary, you cannot really separate them for an accurate quantification of the two of them. You'd probably highlight the entire peak as a single peak and report it as hemoglobin S plus hemoglobin D percentage.
Okay, wonderful. Thank you. Our next question here asks, do you send all hemoglobin variants for molecular confirmation?
The short answer is no. At the two institutions that I've been at, University of Virginia and now University of Michigan, so it depends on a kind of variety of factors, including whether there's a clinical phenotype. So basically, does somebody have disease state or symptoms that is likely attributable to a hemoglobinopathy or thalassemia? That will drive genetic testing in a lot of cases. A lot of the more routine interpretations, we call them interpretations, but because of the complication and cost of genetic testing, we're not routinely confirming all of them. So in like an ideal kind of very academic focused world, we'd love to confirm them all genetically. It's just a question of resources and is it relevant to the patient's health.
Wonderful. Thank you. We have time for a couple more questions, so we'll just keep moving on here. Our next question asks, does alpha thalassemia reduce HGBS?
I think Mark could answer this just as readily as I, but in general, alpha thalassemia is going to suppress the expression of a lower expressing beta variant. So if you have a beta variant that expresses slightly less than hemoglobin A in the trait form, when you add that alpha thalassemia impact on it, generally the lower expressing one is going to go further down. So hemoglobin S, which routinely expresses a little less than hemoglobin A, that gap is going to grow and the S is going to go down. Is that your experience as well, Mark?
Yeah, I think so. And just to make sure everybody's really clear on this point, we're not quantitating these hemoglobins. So it is all a relative amount of the entire hemoglobin. So
yes.
There are some complications to that question depending on treatment and concomitant, thalassemia, et cetera. So.
Excellent. Thank you both. And we have time to squeeze in just one more question. This question asks, on the A1C assay, why do HGBF greater than 23% interfere with the A1C result?
Okay, I believe I can speak to that one in particular because this is very specific to the capillary hemoglobin A1C assay, which of course is related to but is not the same thing as our hemoglobinopathy as screening assay. The simple fact of the matter is that on the hemoglobin A1C assay, when you have hemoglobin F greater than 23%, the peak is close enough to the hemoglobin A that it starts interfering with the system's ability to accurately calculate the hemoglobin A peak. So when you get up to 23%, that's when you're crossing over just a little bit of the hemoglobin A, and in order to calculate A1C percent, that is hemoglobin A1C over A1C plus A0. If you start being unable to calculate that A accurately, then you start getting a little wobbly about how accurate your final calculation of A1C is. It's simply the co-migration of the F over top of the corner of the hemoglobin A. This is kind of unrelated to the hemoglobinopathy screen, but it is a very similar looking pattern, and so you can, those of you who have our A1C assay are able to sort of visualize that in your mind. Up to that point, there's enough separation between A and F that the F is not overlapping enough that it's going to interfere with the calculation. But that's a very simple sort of overview without having any visual aids available to sort of explicitly explain how that looks.
Wonderful. I want to thank you both for your time today and your important research. We would also like to thank LabRoots and our sponsor, Sabia, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by our speakers via the contact information you provided at the time of registration. So please continue submitting your questions as they will be answered. I would also like to remind everyone that there is a post-event survey and your participation in this survey is greatly appreciated. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.